Good afternoon. I am Michelle Williams, Dean of the Faculty at the Harvard T.H. School of Public Health. Thank you for taking time out of your day to join us for this virtual symposium entitled COVID-19, Where Do We Go From Here? We are delighted to present this program to you today, along with the New England Journal of Medicine, a partnership with shared intentions of bringing together the best in science, research, clinical science, and policy translation. Globally, we have been seriously challenged by this pandemic. And what we are witnessing and experiencing today is unprecedented. COVID-19 has infected more than 2.5 million people and has killed at least 171,000 worldwide. And yet, this outbreak is by no means an anomaly. Infectious diseases emerge and reemerge more quickly than ever before, killing hundreds of thousands of people, decimating local economies, and triggering panic around the world. Our healthcare systems at home and abroad are frighteningly vulnerable to disease outbreaks of all kinds. The fact is, life as we know it will no longer exist. Physical distancing and mask wearing in public are our norms for the foreseeable future. Essentially, our ecosystem of welcoming and meeting each other has been completely uprooted. As I watch the national news, as I read multiple papers and journals, I am also in awe of the collective optimism and determination that we will get through this. And I am hopeful that we will. But all of us in public health know the only way forward is through science, research, effective communication, and a greater understanding of how truly interconnected, interdependent, and how fragile we all are. Public health's time is now. I hope this conversation is the first of many to help us figure out what our next steps in this pandemic will be. Please join me in welcoming our special moderator of today, Dr. Jonathan LaPook, Chief Medical Correspondent of CBS News and Professor of Gastroenterology at NYU Langone. John.
Thanks so much, Michelle. Dean Williams. I'm really honored to be moderating this distinguished panel, and I'm looking forward to this conversation. I want to point out that this is being presented jointly by the Harvard T.H. Chan School of Public Health and the New England Journal of Medicine, and hosted by the Forum at the Harvard T.H. Chan School of Public Health. Welcome everybody who's out there on Facebook and elsewhere online. A little bit of housekeeping in terms of Zoom. You will be able to chat with each other, but not with us. The whole concept of whether or not this was expected or unexpected, and Michelle was alluding to, we did a 60 Minutes presentation. This was the first one at the beginning of March about coronavirus. And as part of that, I interviewed Tom Inglesby, who's an infectious disease expert at Johns Hopkins. And I was astounded to find out that back in October of 2019, about 4 months before we sort of were understanding there was a pandemic, there was a symposium at the Pierre Hotel in New York City where they did a simulation, and it was hosted by the Hopkins Center for Health Security, the World Economic Forum, and the Bill and Melinda Gates Foundation. And they did a simulation of what would happen if there were a pandemic of, wait for it, coronavirus. So this was not unexpected. People have been talking about this for years, and I have to read you just their recommendations. This was after this symposium, where they basically predicted everything. The market tanking, industry having the economic consequences, you name it. The next severe pandemic, this was after October of 2019. The next severe pandemic will not only cause great illness and loss of life, but could also trigger major cascading economic and societal consequences that could contribute greatly to global impact and suffering. So this was not unexpected. Michelle Dean Williams was talking to me beforehand. When you think about a theme, I remember the 1964 World's Fair in Flushing, New York. The theme was peace through understanding. And the theme here is closing the gap between what we know and what we do. This is from Dean Williams, and I think it's a great theme. So I want to go forward. I want to talk about the theme of embracing science, which is so important right now, about the role of public health. Joining us today are Eric Rubin, who's the editor-in-chief of the New England Journal of Medicine, professor of immunology and infectious diseases at the Harvard T.H. Chan School of Public Health, and a physician at Brigham and Women's Hospital in Boston. Hello, Eric. Caroline Buckey, associate professor of epidemiology and associate director of the Center for Communicable Disease Dynamics at the Harvard Chan School. Harvey V. Feinberg, president of the Gordon and Betty Moore Foundation and member of the editorial board of the New England Journal of Medicine. And Arnold Epstein, who's professor of health policy and management and chair of the Department of Health Policy and Management at the Harvard Chan School. And we're going to first hear from Eric, Caroline, and Harvey, and then we're going to have a broader discussion, and then Arnie will provide some closing remarks. So welcome all. And Eric, you're up.
Hi. Thanks. So I just got off of the clinical service yesterday, and so I've been seeing a lot of patients with COVID-19, and it really changed my thinking about the epidemic. As an infectious disease specialist, we're there to answer people's questions, to make suggestions to the teams that are caring for these patients. And I have to say, it's incredibly frustrating right now. There are a lot of potential tools out there. There are potential treatments that people are using and other sorts of interventions. And we're asked, which ones of these should we choose? Which ones of the off-the-shelf reagents, off-the-shelf drugs could help people? And the truth is, we have no idea because almost nothing has been rigorously tested. In this pandemic has now been going on for a couple of months, and yet, for most of us working in most hospitals, we can't even enroll patients in good quality, randomized, controlled trials to figure out whether or not these interventions are really making a difference. So I think my takeaway from that is that we need to be doing a lot more, that we probably should have already been doing a lot more, but at this point, we need to make those changes and figure out what tools are we going to have to try to help people and try to control the epidemic.
So, Eric, that's such a great point. And of course, I'm noticing that at NYU Langone too, where I'm a professor of medicine. You have this friction right now, right? Between these patients who are so sick. They are sick as hell. And I was an intern in March of 1981 when HIV came along, and those patients were really sick, but we weren't seeing it as communicable. We weren't seeing the whole system, the whole healthcare system overrun. So you have people coming in, they're sick as hell, and you want to give them something. So people come in and they get hydroxychloroquine and Zithromax and zinc and anticoagulation, low dose, high dose. They get enrolled in an IL-6 trial. So you have this desire, which is natural and understanding, to do something for especially the sickest patients. But then you have the other side of, how do you do the controlled studies? It seems to me that it's hard to do those controlled studies when people are so sick. So do we have to be concentrating maybe on the people who are less sick, have milder disease, or even people who are asymptomatic and who are the contacts, for example, of somebody who has COVID-19?
So I think there's the question of equipoise. When is it fair to not treat people with drugs or not treat people with something that might help them? We dealt with this during the Ebola epidemic. During Ebola, many people felt that using a drug was that was potentially helpful, was better than nothing. And the consequence of that is that we tried some agents in uncontrolled trials. They looked like they might work. And in retrospect, when more controlled trials were done in the later on in the next outbreak of Ebola, it turned out that many of those were not actually effective. So I think we need to learn something. I think that we're helping everybody by enrolling these patients in trials that actually give us an answer we can understand.
Yeah, and I wondered whether we're really even understanding what all the variables are that we should be measuring. For example, there are 4 or 5 different kind of ventilators, right? There's the ventilator that's used in the ICU, the one that's used in the operating room, the one that came from FEMA or from our national stockpiles, and then is that a variable that we should be controlling for? So anyway, these are all
absolutely. And if I can follow up for one more minute, I think that the ability to look at patients at multiple stages of disease in this disease is very important. So you suggested that we should be looking at patients with mild disease. It could very well be that that is really different, where viral replication is very important to the disease, where later on inflammation might be important. And so they're almost 2 different sets of patients.
Caroline, you are an epidemiologist, in case you didn't know. Your stock could not be higher than right now. So talk to us, teach us, what do we need to know?
Well, so I think this epidemic has unfolded in this country as expected, to start with, in cities that were highly connected to other parts of the world that had COVID-19. But since then, it's spread pretty rapidly to the rest of the country. So right now, different parts of the country are actually at different stages of this epidemic. Places like New York are well into their first wave. Other places are just beginning to see the impact of the disease. And of course, there are important epidemiological timelines here where, when you become infected, you're spreading the virus, but you don't show any symptoms for about 5 days or so. For people that end up in the hospital, that takes another week. And then disease progression from there to death takes another, week or more. So there's a long time lag between when people are becoming infected and when we're starting to see an uptick in deaths. And I think that really highlights the important problem here of lack of test capacity. This has been a problem from the beginning, and it continues to be patchy. And the reason that that's such a problem is because this disease has a very broad clinical spectrum. There are people that show up at the hospital, and even if they're getting tests, there are many more cases in the community, mild cases or even cases with no symptoms at all for the duration of their infection. And those are the people that are spreading the disease. Right now, we don't have good estimates for where we are on the epidemic curve in different places. So discussions of relaxation of physical distancing, which do seem to be having an effect at curbing some of the worst impacts of the outbreak, need to be based in a capacity to test people so we know where we are. And of course, there's 2 different types of test here. There's testing for presence of the virus, and there's testing for presence of antibodies to the virus, which is an indication that you've been infected sometime in the past. Until we know how far along the epidemic curve we are, we can't really make informed decisions about opening up and how to do that in a sensible way, because we simply don't know whether we're close to the first peak or not. And of course, we should look back at the 1918 flu epidemic and learn from that, because often when we start to relax interventions, we could see a second wave that could be even more deadly. So really understanding where we are in the epidemic curve, which will be different in different places, is where we're at. And I think that, again, the call for testing is the most important, but also these antibody tests are going to be very helpful as well.
I couldn't agree with you more. And just for the people out there who are not as deeply steeped in the science, the one you're talking about, which says if you have active viruses, the nose or throat swab, that's looking for the PCR. That's the PCR test, tells you whether you have the infection now. And there have been some problems with that, with false negatives. Then the antibody test, or the serology, it's a simple blood test. It's ready in a few hours. It's technically not hard to do, very similar to the way we have been testing people for immunity to measles, mumps, and rubella. 4 million women give birth each year. This test is done widely. And yet right now, there are 2 different types of those antibody tests. The one that's the rapid one, which is pregnant or not pregnant. It gives you a line saying you've got the antibody or not. The other is the ELISA, E-L-I-S-A, that can actually give you an idea of how much antibody, right? But we're having problems with those technically, aren't we? And some of those tests that came out originally, they were giving false positives because, for example, the coronavirus is part of a family that includes the common cold, that in about 30% of the common cold is coronavirus. So we were seeing false positives, and it's worse to have a bad test than to have no test, right?
Well, I think any test has particular characteristics. There's always going to be some kind of sensitivity issue, and there are a number of tests now that are being cross-validated against each other to make sure that they're giving interpretable answers. But I think the key is just to make sure that when you do the study design and the statistics on the other end, that you're accounting for possible false positives appropriately. So we're not making spurious estimates about how many people have had the virus or have not had the virus. So I think these are manageable uncertainties, and as the tests become more available, we should be able to handle that. The key is to get study designs that are as unbiased as possible, and start to make sense of them so that we can figure out how many people didn't have symptoms at all, the extent of community transmission. We've seen particular low-income communities hit really hard by this outbreak, and we need to try and understand what's happening with the epidemiology before we can make any plans for relaxation of physical distancing.
All great points. And I want to set this up for Harvey because we all know that in recent days, there have been some preliminary results of this antibody testing in community that suggests it's a lot more prevalent than the ones that are reported. If it's a lot more prevalent, then the denominator is bigger, the mortality rate would go down. But on the other hand, it means that a lot more people have been out there spreading it. And as you say, asymptomatically. So Harvey, we have this, it's been framed that it's either we save the economy or we get our arms around COVID and we treat COVID. So, but we can get our arms around both, right? So that raises the question, if let's say the antibody test works and it's widespread and people get it and it shows that they have antibodies, does that mean they're protected? Is there an asterisk there? Is this going to behave like other viral infections where you do get some protection, or it's a novel coronavirus? We don't really know. And if we don't really know, how do you think about returning to the front lines and opening up the economy? So I'll throw that very easy question to you.
So thank you so much for the question. I really resonated with the points that Eric made about the importance of learning in the clinic, and the points that Caroline is making about learning in the community. Where do we stand? What works in the clinic, and where do we stand in terms of the infection? And you've raised a really important perspective. This is not a choice between dealing with the epidemic or dealing with the economy. We have to do both, and we have to do them successfully. And the question really is, over time, given what we know and what we don't know, including, for example, the uncertainty about the degree to which antibody being present actually confers resistance to illness. That is something that is not well established for this virus as yet. Nevertheless, we do know a lot that could help us in beginning to plan for reopening in progressive and limited ways different aspects of the economy. For example, with a respiratory virus, we know it is spread by droplets of various sizes. Some are visible, some are invisible, some may be so tiny that they could be aerosolized. With the case of SARS-CoV-2, we don't know exactly the proportion in each of those sizes, but it's pretty clear it's spread the same way many other respiratory viruses are spread. So what does this mean in terms of risk? We know that having people close to one another is a risk. That's why you separate people. We know that having many people together is a risk. If each person that you might encounter at random has like a 2% chance of being infected, bring 10 of those people together with you in a room, you've got more than a 1 in 5 chance that somebody in the room is carrying that infection and could spread it to others. How long are you together? The duration of interaction, that affects the likelihood of spread. What are you doing during the interaction? Are you just sitting quietly and eating, or are you cheering at a sporting event or shouting or singing in a choir? And finally, what's the physical environment like? What's the layout? What are the degrees of protection, the separations, perhaps the use of air purification, germicidal, ultraviolet, and other mechanisms? So right now, it is not too soon for every sector in the economy, whether you're a university, a school, a workplace, a factory, any gathering spot, to begin to think through, given what we know and taking advantage of what we will learn, what would be our best practices today for beginning to approach a more nearly normal way of interacting. That's a part of coping with both the economy and the epidemic that I believe could use a great deal more concerted attention from leadership across the entire spectrum of enterprise in our country.
So let's open this up to a deeper dive in. I think what people really want to know is there are huge issues. I was saying we could go down the rabbit hole on so many different things. And so many of these issues are so important. And Caroline, the healthcare disparity issue, huge. We're seeing Black patients who are more affected, sicker than white patients. Why is that? I want to cover them all. But I also want to talk about specifically how do we move forward towards opening up the economy. That's what we're seeing in the news. We're seeing some states relaxing their restrictions. How wise is that? I want to start with testing. So we're seeing the CDC has two different criteria for you've been infected and now you want to return to the workplace or to society. One says no fever for 72 hours with no aspirin or Tylenol or NSAIDs or anything like that. You're feeling better and it's at least 7 days since you first had symptoms. The other says that you have to have 2 negative throat swab tests by PCR at least 24 hours apart. And yet, they rub up against each other a little bit. When you look at some of the studies, for example, out of Germany, of those 9 patients where they found that people were shedding in their throat weeks after their illness, and yet they didn't have infectious particles past day 8. So question number 1 for the ID people, how do we get our arms around this? How do we think about when it's even safe to go out? Question number 1.
So if I can start on that one, I think you hit on a very good point. The tests that we're doing are entirely, the clinical tests are testing for the viral RNA, the nucleic acid that encodes the viral particles, rather than the virus itself. There are developmental tests for looking at the virus, but they may not be very sensitive. In fact, it's technically very difficult to isolate virus and very few labs can do it. What we really care about is, can these people transmit, not whether or not their tests are positive. And how do you tell that? You might be able to tell that by isolating virus, but we know that's a very insensitive test. What we really need is some epidemiologic data to tell us, are people who have left the hospital going on to transmit disease? That's sort of the shoe leather epidemiology, contact tracing, following what happens to the contacts of those patients, which takes some manpower. But it's a really critical question. I think we can't just make assumptions. Right now, the CDC, to their credit, they have to set guidelines of some sort. And you're right, there are 2 discrepant guidelines out there, but it's better to have something than nothing. But I think this is a question that really, one of the many questions that really needs to be answered.
If
only
we had an epidemiologist here. Caroline?
So I was going to just follow up and say that this issue of case finding and contact tracing is going to be critical with any release of physical distancing interventions. You have to have a system in place where you can do case finding, follow those people, test them appropriately, and manage the data that's coming out of a contact tracing system. And that's key. And I think we should also keep in mind that it's not going to be the case that you have contact tracing and everything else goes away. We're going to have to do this in a careful, staged way, with certain sectors opening up, certain populations able to start thinking about going back to work. But it has to be responsive to sudden changes and if it looks like a big resurgence is happening. So we have to be able to tune this a little bit. The only way we can do that is if we're testing sufficiently that we can monitor what's going on with transmission, and rather than waiting until we have an uptick in deaths 2-3 weeks later. So I think that the key is that we have to be adaptable, and the way to be adaptable is to have enough situational awareness that we can make smart decisions, and that relies on testing. And I'm talking about, virological testing here. So I would agree with Eric, and I think that any plan to to relax these interventions relies on a system in place for monitoring what goes on subsequently.
I think this brings up the issue of communication with the country, the public health communication. So when I was doing this 60 Minutes piece at the beginning of March, I interviewed Dr. Tom Inglesby, who's an ID guy from Hopkins. And I said at the end of this whole long interview, I said, you can understand the instinct that public health officials or that government officials would have to want to reassure the public. And he said, John, we are not departments of public reassurance. We're departments of public health. And oh my gosh, did that ever hit home to me? And we went back and forth a little and got to the point of that, even if you're telling people news that's worrisome, if they know that you're leveling with them, if they feel that you're telling them the truth, the whole process in and of itself is reassuring, even if the news is worrisome. So this brings us now to this next stage where we are now, where you have a federal government, but you have 50 states and territories beyond that, people doing, some of it's coordinated, some of it's not coordinated. How do we communicate to everybody who are not scientists in a way that they can understand what to do next? Harvey?
I'll start. This is almost a question I think we could go back to Dean Williams and ask her opinion on this as well. We don't in the United States have a singular voice about anything. We have leadership at multiple levels. We have technical leaders, we have political leaders. We have leaders in the health sector, we have leaders in the industry and business sectors, all of whom have a voice. The question, I think, and the challenge for public health often is how do you communicate clearly and honestly about some of the uncertainties that surround a number of the considerations that you are taking into account when you come to a recommendation or a decision. When the health commissioners in the counties of the Bay Area of California came to the conclusion that it was important for everyone within their jurisdictions to now work from home, stay at home, be separate from one another, it was not because they had absolute certainty about what could and was happening, but enough evidence had accumulated, they had reached a clear and very compelling conclusion that they communicated with coherence, with coordination, and with great clarity. And those are very important features for conveying a public health message to the larger public. I do think it is an ongoing challenge for health officials to be both decisive and clear and sensitive to the uncertainties that underlie what their recommendation rests upon. And this implies, getting back to the very first points that we were talking about, being not only willing but eager to continue to learn in real time more information that shapes and informs the public health recommendations.
Harvey, if I can follow up with a question, and it's probably really for both you and Caroline, one of the areas that has a lot of uncertainty, has uncertainty built into it, has been modeling. And models are out there in the public, they're constantly being discussed, and they're helping to shape public policy. How do we communicate the uncertainty in those models and why there are different groups producing different sorts of numbers out there?
I can speak to that a little bit because I do a lot of modeling. So I think there are so many different approaches to modeling, and they are fit for different purpose. So, the appropriateness of the model to answer a particular question is something that's very important, and I think is probably not well communicated, or could be better communicated. Often the model will change, the model results will change because these models rely on assumptions about human behavior. And all these interventions and physical distancing interventions that have been happening, we don't exactly know how that's impacting the contact rates in the models, for example. So it alters what we think about what's happening with the peak. I think that uncertainty, communicating uncertainty, is a challenge because policymakers and the public want answers, and there is a strong incentive to downplay the uncertainty sometimes in model projections. You know, and so when you're making a model that is designed to understand multiple different scenarios for how we might unroll physical distancing interventions versus trying to make an estimation for how many people to expect in a given hospital in a month, those are completely different frameworks. So part of it is just a kind of communications and outreach issue where modelers need to be much more clear about what their model is for and where the uncertainty lies. And personally, I think that we need to have a much more open discussion about that. And I think that models need to explicitly include discussions of uncertainty whenever they make some kind of projection.
I love
Caroline,
that point, Caroline, so much. It gets to the issue of who's communicating this. So scientists we're comfortable with uncertainty. I mean, we know, you know, medicine and science, it's an eternally humbling profession, right? You know, if you've been a doctor, I always say for 5 years and you have any hubris left, you're in the wrong profession. So we know that things changed. 1,000 years ago, we were drilling holes in people's heads to let out the evil humors and vapors, and we don't do that so much anymore. We know all the things that have changed: hormone recommendations, vitamin D recommendations, vitamin E recommendations, you name it. So we're comfortable with uncertainty, but I don't know that we're communicating that adequately, that this is uncertain, and that the data is, as the data changes, we're going to change the model. We're going to change our recommendation. I know I said that a week ago, but that was based on the current data. And that's why I think when we're communicating with the public, and you see this beautifully with Dr. Fauci, with Tony, is that he's very careful about the words that he chooses. And that's the way a scientist talks, as opposed to saying, look, this is the story right now. And I think we have to give the public credit to be able to understand that nuance, because otherwise it's confusing to them.
Yeah, and I think I think sometimes people confuse these types of models for weather forecasts, and the weather forecast isn't going to change. The uncertainty is going to reduce over time, but our actions aren't going to change what's happening with the weather. With an epidemiological model, people's collective action changes the outcome. So it's a very different thing. We're not going to just gradually improve our ability to forecast necessarily, because we have all these feedbacks that are to do with human behavior. And that makes it much more uncertain than I think people would like the results to be. So
that brings us to human behavior, a slight variable here, right? Right now, we're seeing the pressure to take the foot off the gas pedal. It seems to be getting better in New York City, where I work at NYU Langone. We're seeing the number of admissions go down, the ICU stays going down. Still, people are really, really sick. So there's a tendency to say, let's just relax. This is we can now go out and do things a little bit the way we used to. I think right this second in April, several months after this started, it's a very tough moment psychologically. And I'm finding that with my patients, because at the beginning, it was you're in fight flight, we're doing this, and now it's sort of getting a little bit, it's almost like a grieving process. And I remember when my mother died in 2009, she had been married to my father for 66 years. And about 3 months after she died, he said to me, "John, is it okay I'm pretending that she's at the hairdresser?" So right now is the moment where we're realizing we're all cooped up. I haven't seen this person. I haven't hugged that person in 3 months, and it's starting to get on people. And you see this in the streets, people having the rallies and the signs and everything like that. So what say you about how we address that? What do you say to people?
Harvey, you've written a whole editorial on this.
Well, I do think it's really incumbent on our leadership, both political and public health, as well as industrial and business sectors, to convey to the public as accurately and with all the uncertainty attendant what the likelihoods are of the consequences for action of different kinds. What will happen, most likely, if we change the way in which we behave. This is another reason why I believe, with all the pressure, John, that you're describing about getting back to a more normal way of interacting, that it's especially important for us to figure out how do we do that in the ways that most likely reduce the risks of this infection being transmitted. I also believe it's very important, as we do that from a health and clinical point of view, to be capable of identifying the cases, tracing the contacts, isolating individuals who are infected or exposed, and having the capacity to treat an escalating number of cases should it occur. So this gets back to our very first point of discussion about the importance of testing and managing the numbers in an appropriate way. We're going to have pressure in different parts of the country to different degrees to relax some of the physical distancing, to get back to normal, to interact in a way that we used to. In my opinion, life in the time of coronavirus is not ever going to be quite the same as life prior to the coronavirus. And we are going to have to learn about different ways of interacting, avoiding shaking hands, for example, relying on the face masks in public places and closed spaces, maybe taking our temperatures in a more regular way, and certainly having in place a more effective and wide-ranging testing regimen. These are all part of the underpinnings of successful communication, because successful communication over time has to stand on a foundation of truthfulness about what is happening and what the uncertainties are. And that is the most important message, I think, for anyone who is in a position of responsibility to communicate to the public.
So Harvey, it sounds like what you're talking about is leadership, and that's not, and of course we think political leadership, but that means leadership within all of our communities, that we are sending not necessarily the same message, but a coherent message to the decision, to policymakers, and that those policymakers are people who are receptive to those. I think there have been examples thus far in the outbreak of very strong leadership and not so strong leadership. And it's certainly part of our responsibility to be helping as much as we can, helping our own leaders make those good decisions.
I'd love to, oh, go ahead.
No, it's okay. Back to you, John.
I'd love to talk about some of the partnerships and some of the lessons that we're learning as we're going. We're in the middle of it, and people have said it's kind of like building a plane as you're taking off. That old analogy or metaphor. I realize that next month I will have been a doctor for 40 years, which is astounding to me since I graduated Columbia PNS. And I was, as I said, I was there in March of 1981 when I saw my first patient with AIDS. In all those years, I've never seen the entire world working on one problem. One problem. It's really astounding. And when you see when you see a paper coming out and it's quoting a paper that was published 2 days earlier, again, it may not have been peer reviewed, but when you see the flow of information like this so quickly, it's really astounding, and it's really uplifting to see this kind of communication. I wonder if we could talk a little bit about the risks of it, about having things that are not peer reviewed, because now we're just saying, what the heck, same like the importance that Eric was talking about actually doing controlled studies, and not throwing science out, even though there's a pressure to do that. We got to embrace science now. There are amazing public partnerships, public and private partnerships. You're seeing companies that make cars turning joining up with a company that makes ventilators and making ventilators together at a much greater rate. So I wonder if we could talk about maybe some of the new structural things that need to change in terms of how we move forward with this kind of unprecedented situation.
Well, I would say from my perspective that the collaborations that are happening so fast, and not just within the US, but international collaborations, experts from all different fields. So, it's very easy to use the word interdisciplinary, and it often doesn't mean much. But in this case, we're seeing truly interdisciplinary teams, different sectors collaborating to come together to solve these problems. And I think it's going to break some of the entrenched problems with academia. I hope that's one positive outcome, where we start to recognize that science is done by teams, and it's done in ways that are not constrained by discipline, and it's done in ways where you can't recognize first and last authorship as the most important feature of who's driving. So I think that it's really changing how science is being received, both by other scientists and by the public, as well as how these interdisciplinary teams are constructed. And I hope that moving forward, we'll be able to provide vehicles for that to happen. The other thing is that, we're seeing the reliance of many policymakers on scientists, academic scientists. And at the moment, I think it's exposing some bottlenecks where there just aren't enough experts to go around that are going to be able to adequately support every local decision maker. So maybe there needs to be a shift in our kind of expertise more broadly to try and to create a better connection between science and policymakers in the future, because that's been a highlight, and also kind of emphasize the importance of that connectivity.
Without being too trying to sugarcoat things, I think we all have noticed there have been some potential silver linings to this. It's a terrible pandemic, and there's been tremendous suffering. But one of the things is that we've all been running, all of us, 200 miles an hour towards what? And this has been a Control-Alt-Delete. We just I almost feel like we've been given a timeout. And I don't like the term social distancing. I think we are physically apart from each other, but socially, we're reaching out to each other with Zoom calls, which of course are not the same as a hug. You don't get the oxytocin surge with the Zoom call that you get with a hug. But I do wonder, and this is not so super scientific, but what people think about this moment in time. My mother, when she was about to peel an orange, she would hold the orange in her hand and she would say, at this moment, this orange has never seen the light of day. And then she would peel it, this orange, this moment. And there's today you would call it mindfulness. Back then it was just my mother peeling an orange. But I wonder whether it's sort of just taking stock of our lives, or the fact that there are other potential things coming out of this. Now that we're doing social distancing or physical distancing, I was speaking to Dean Williams, to Michelle, is there going to be a drop in the amount of flu this season? Because after all, it's spread that way. Are we going to see a decrease in foodborne illnesses, which are millions of cases a year? So I wonder a little bit, we know it's a terrible time in terms of suffering, but some of the potential collaborations, partnership, silver linings that might come out of this.
So Caroline, go ahead, Eric.
Go ahead, Caroline. No, go ahead, Caroline, or Harvey.
Yeah, I was just going to say, science is one of the universal languages, like culture, music, the arts. It is one of those enterprises that really knows no national boundary in terms of its core function. And so collaboration around the world through science is one of the ways, as Caroline was emphasizing, that could be a lasting and more durable result of the urgency and the exigency of the COVID-19 pandemic, even beyond the time of coronavirus. Also, I think from my vantage point, this epidemic is simultaneously a public health crisis, a medical clinical care crisis, an economic crisis, and a social crisis in terms of disruption, separation physically as you're describing, and dealing with one another in very different ways than we're accustomed to. how we progress through each of those crises will define who we are as a civilization coming out of the COVID-19 experience. And that will have some benefit, no doubt, in terms of adaptation, and maybe even, as you're suggesting, John, reductions in the transmission of other respiratory diseases if we take steps more generally to reduce transmission in the ways that we've been discussing. And from a social point of view, maybe it will help restore in us a sense of the importance of those connections one to another and the opportunities and value that we attach to the kind of intimacy and social interaction that we naturally cherish as human beings. So I do think that there will be changes, some of which could be in the long term to our benefit, but we are going to have a really rough, disruptive time moving from where we are to where those ultimate improvements in some areas could take us.
And I think that brings us to this has been so fascinating, and I want this to go on another 3 hours. There are so many other things that I want to hear from you guys, and I come back to the structural inequities that are already so apparent, healthcare inequity, and how this disease is impacting different populations. And the other thing we didn't even start to talk about is why this happened in the first place. Are we encroaching on nature, and we're seeing animal viruses hopping into humans as we there have deforestation, the role of that? Are we going to learn lessons? What lessons are we going to be learning from that? This has been so great. We're going to go to Arnie for some closing remarks, but first we're going to go to each one of you for sort of like one key takeaway. So we'll start with Eric.
To get back to Harvey's point, which I think was so nicely made just now, one of the advantages that we have right now is we understand a little bit of our own frailty. And I think this sets us up well for the next crisis that should come. There will be more pandemics, we know that, but there are other sorts of crises, and hopefully we're going to learn some lessons from this that we can take forward next time around.
And Caroline.
So I would just say that this epidemic is global, but our response to it has to be local because it's happening on different timescales in different places, and the health system is going to reflect the local reality. So I think communities need to be making decisions that reflect where they are in the epidemic and what resources they have moving forward. So again, just testing in order to be able to know where you are and to be able to respond if there is a resurgence. I think that has to be the first and most important point.
Caroline, is there a specific, like if you were king of the jungle or queen of the jungle and whatever you said went, is there something that you're seeing right now in the news that makes you think, no, you got to turn a screw a quarter of an inch in your head and do it this way instead of that way?
Well, I wouldn't be considering opening up society until I had testing in place, period. So I think that would be my decree as queen rather than king.
I know. I did catch myself in my defense, but it was a reference to the Wizard of Oz. We are victims of our upbringing there. What does that mean, adequate testing? Because it's in the eye of the beholder, right?
Yeah, so of course we talked about antibody tests versus diagnostic tests for the virus. The first need is diagnostic tests. So if we're going to do case finding and contact tracing, you need enough tests. You need to be able to test people, you need to be able to test their contacts, and so on. And that's the first thing that has to happen. And then we need broader serological or antibody testing in the community so we can understand the extent of the epidemic so far, so the cumulative number of cases that we've had.
I have to ask you one more question, which is, I've been reading the 1918 pandemic, and it seems like as you look back through history at pandemics and at outbreaks, there's always this reflex to blame somebody, We saw it with Ebola, where people from West Africa, we see it here with racism against various groups, people from Asia. We're seeing all sorts of incidents. So can you talk to me about that?
Well, I would say, echoing what Eric said, the hope is that this makes people realize that we're all human and we are all connected in very fundamental ways. We are all at risk. We are a globally connected population. The problem with a crisis is that it exposes some of the bigotry that is present already in a population. And of course, racism is still with us and will continue to be with us. So again, I think it's really important that there's a leadership around communication here, and people understand that this virus is agnostic to who it infects, but the structural inequalities and chance plays a big role in who may be infected first and who is going to be hit hardest. But really, we have to recognize that the virus infects all humans, and we live in a global population. So we really need to have that at the forefront of our mind and our policies and our response.
That's great. And Harvey?
Building on this discussion, I would add that this epidemic really won't be over anywhere until it is over everywhere. And that means not only attending to the differences within the United States and the varieties of expression and stages of the pandemic, but it means a genuinely global outlook of collaboration, cooperation, and joint purpose with colleagues and counterparts in countries all around the world. If we don't really collaborate and work together to defeat the coronavirus in the world, no one country will ultimately be secure from the coronavirus. It's as simple as that.
On a positive view, have you ever seen this degree of collaboration in your entire career that's happening right now?
Well, if you mean across scientists and getting everyone's attention, I would say this is at a heightened level that has not been equaled by any singular event. I go back, as you do, to the HIV pandemic, and I think that was also a moment spread out over a longer period of time that also dominated thinking of many, many scientists and other elements of society. Maybe that's in our lifetimes a health counterpart, but this is calling upon a new level of common attention that we have seldom seen.
Great. Lots of wise stuff here. I'm learning a ton. Arnie, you're up.
I've been listening carefully, and really it's been extraordinarily interesting. I want to thank the panel for what's been informative and thoughtful and really engaging. And there's a lot to weave together here. I'm thinking first that as you were talking from the very beginning, I was feeling somber. And I think it started when you started talking, Eric, and you mentioned that you've just come off clinical service. I know what that's like, clinical service, and that you were hard pressed to name a single therapy for which you thought there was really good evidence that it would work. And I thought, wow, that's interesting. We're a country that put man on the moon. We've put probes on Mars. And when it comes to having a patient with COVID-19, we might as well be in the 1600s. And then I thought of the remarks, Caroline, that you made about testing being so important, and Harvey coming back to that. And in your writing, you talk about monitoring a lot. And that level of testing that we need, we still have not produced. Still not there. So it leaves me wondering, really, how we're going to get this going. What's next in front of us now may seem almost overwhelming. I thought I would try and put together 4 observations that will put in context what we've been talking about. The first is the irony. We've been having increasing globalization for quite a number of years. The major industrial countries all have their economies intertwined. And at some level, we all knew there was a likelihood that someday we might have a pandemic. Maybe not so much like the folks at Johns Hopkins, but I think your point is well taken. But what stands out to me is I don't think many of us, not me, anticipated the degree of dislocation in healthcare and health policy, the degree of changing our way of social activity, the destruction of the economy, with now millions and 10 millions of people suddenly unemployed, many of them uninsured, some of them unable to sustain their life without food handouts. That's an enormous change. It is, as Michelle said at the beginning, a change we're not going to, and Harvey said it too, we're not going back anymore. It's going to be really different going forward. Second point I want to make is this has been a really interesting time for the medical healthcare system. It is both their final hour and where their soft underbelly of concern is evident. Every morning, physicians, nurses, thousands, tens of thousands of hospital staff go to work for 8, 10, 12-hour shifts where they care for patients with COVID-19. And they've been doing it miraculously enough, often without masks, without gowns, without gloves. Nothing less than totally heroic. And unfortunately, many people have paid the price. At the same time, there are challenges. While we're seeing heroic action in American medicine, there are challenges that are fanning the flames, which you call the structural difficulties. We have a two-class healthcare system a lot of the time, and certainly the disadvantaged populations here, the indigent, minorities, blacks, Hispanics, have really gotten hit hard indeed. I want to build up on another theme. Harvey talked about the pluralism of decision makers, and I think it's important across all sectors. I want to emphasize how fragmented and pluralistic our country is, with 50 states, and even in those states, enclaves, and each with a different cultural background, different ethnicity, different volume, all quite different. And in those differences, asking the question, where do we go from here? We're not going one place from here. We're going to go multiple places, reflecting those different divisions, the different states, the different patient groups, the different ages of the different patients, and the different stages that we have in the epidemic. Finally, let me say that I think this is going to be a long haul, really long. You know, they say euphemistically, if we're lucky, we'll have a vaccine in 15 or 18 months. What happens if we're not lucky? There is no tried and true playbook here. The euphemism or the metaphor that you were referring to was we're stuck flying the plane and building it at the same time. Well, that is exactly right here. And worse than that, there's no air traffic controller to give us guidance out there. Ready or not, I think we're going to have a massive natural experiment that will be prolonged and fueled by decisions coming out of states, multiple municipalities, and then all the different sectors that Harvey alluded to. I'm hopeful with that monitoring, we will get, with monitoring and study, we'll get to a good place. The one part I'm pretty sure of is that our chance to be successful will be higher if we put together the voices from medical science and clinical medicine and immunology and epidemiology and public health policy all together, much as we have today. Back to you, John.
Thank you so much. We need to end this discussion. It's been really great. Thank you to Dean Williams and all of our panelists. And Dean Williams, of course, you don't have to be smart. You just have to know somebody smart. That person is Michelle Williams, who said, the goal here is to close the gap between what we know and what we do. I think nothing could, encapsulate what we need to do better than that. I want to thank the Harvard Chan School and the New England Journal of Medicine for presenting this event, to the forum for hosting. A video of this presentation will be made available on the Facebook pages of the Harvard Chan School, the New England Journal of Medicine, and the forum, as well as on the Harvard Chan YouTube. Thank you all for coming today, and we ended exactly on time, 1 o'clock. Thank you all for coming.